Manish Katikar, Dr. Sri Ganesh, Dr. O Baby, Dr. Debasis Swain. Welcome to all the chairpersons. Next, we have Dr. Saikat Sen Gupta. Over to Dr. Saikat Sen Gupta.
Thank you, ISA Kerala State Branch and Dr. Venkatagiri for providing me with an opportunity to speak on airway management in complex maxillofacial trauma, a case-based presentation. What I will take you through are certain clinical scenarios of a patient whose airway needs immediate attention, a patient who has an anticipated difficult airway, and in a setting of complex facial-maxillary trauma, a patient whose airway management can wait and does not have an anticipated difficult airway, and finally, how the surgical procedure is influencing airway management. Where would you be required to take control of the airway? It could be in the A&E department, in the intensive care, or possibly in the operating room. And your assessment is essentially to figure out how time is critical in this situation. Is the airway anatomy anticipated to be difficult? And finally, in the OR, is the surgical procedure going to influence your airway plan? Always assume in these scenarios that they will or may have cervical spine injury. And in your assessment, if you find that the patient is conscious, breathing spontaneously, try and ensure that they have both while you take control on the airway. The assessment will try and answer ventilation and oxygenation, but unique to this scenario is the anticipated clinical course and what is the chance of the airway to deteriorate. Remember, this airway is a very, very dynamic airway. Time is extremely critical, and certain patients who needs immediate control on the airway are unresponsive patients, inadequate respiratory and ventilatory functions, struggling to breathe, incapable of protecting the airway due to the teeth, broken bone fragments, foreign bodies, etc., etc. Be aware that conditions might deteriorate very, very soon. For example, a soft tissue hematoma can lead to a complete airway obstruction, and if you have not taken control, there is a very slim chance that you have later for success. A posterior inferior displacement of a fractured maxilla can obstruct the nasopharyngeal airway. A bilateral fracture of the anterior mandible might cause the fractured symphysis along with the tongue to slide posteriorly and obstruct the oropharynx. Be careful about that. So, which are these situations where they have a potential to be compromised? If you witness bleeding into the oropharynx or the nasopharynx, if you see that there is subcutaneous air or crepitus in the neck or in the front of the chest, hematoma in the neck or the lower part of the face, hoarseness of voice or other alternations, or a subjective sense of shortness of breath despite adequate oxygen saturation. If the answer to any of these is yes, it is prudent to secure the patient's airway early before it deteriorates significantly. There's a note of caution. Even if you're not securing the airway, remember to re-examine these patients very, very often, the vitals as well as the airway. As I said earlier, the airway is going to be very dynamic in this scenario. How will you anticipate that this person might have a difficult airway? It's standard. Is there a potential difficulty with bag mask ventilation, with endotracheal intubation, with the placement of a supraglottic airway, or there is a potential difficulty with the front of neck, cricothyrotomy or tracheostomy? There are certain mnemonics that go with the assessment of a difficult emergency airway. One of these that we begin with is the lemon, which starts off with look externally, and it follows the Gestalt law. If it looks bad, or worse, it is going to be bad. Difficulty with bag mask ventilation goes by Roman. And there would be certain things like if the person has radiation, has obstructive sleep apnea, no teeth, anyway, bag mask ventilation is going to be difficult. But you add to this unique scenario of the trauma causing furthermore upper airway obstruction and problem with mask seal, because disfigurement of the middle or the lower face of the skin and bones can cause difficulty in face seal, as well as obstruction from heavy bleeding, soft tissue swelling, hematoma can interfere with effective bag mask ventilation. Along with this, bag mask ventilation can actually make things worse. Like a subcutaneous air in the neck, a breach in the airway, positive pressure bag mask ventilation can drive more of the air into the subcutaneous area, tissues and have no effective ventilation. At the same time, it can also possibly worsen the already distorted anatomy and that was already there. It has been reported that bag mask ventilation can worsen the neurological status, especially with nasoethmoid fractures and fractures of the anterior cranial fossa. It can force the infection debris into the brain. And if there is a tear in the dura, there is a potential to develop tension pneumoencephalus, further deteriorating the neurological status of these patients. Keep these in mind. Laryngoscopy and intubation can be difficult because, again, bleeding, soft tissue trauma, disruption of the normal anatomy can obscure the view of the glottis. And if you have to assess mouth opening with the cervical collar in situ, you might have to open and then find out. Placement of supraglottic airways might be difficult, goes by the mnemonic of rods. And in this setting, obstruction, opening of mouth, distorted airways, presence of debris makes it even more, can make it even more difficult. Difficult front of neck goes by the mnemonic of SMART. And in this setting, which adds to it, is the presence of an hematoma in the front of the neck. Axis of the anatomical landmarks can be disrupted because of this trauma. Coming to assessment prior to surgery, try and figure out what is going to be the surgical procedure. Do they need occlusion? Do they need intermaxillary or maxillomandibular fixation? And your airway plan will be then accordingly. Coming to management, the guiding principle is to secure the airway as early as you can. How critical is time? And again, is the airway anticipated to be difficult or not anticipated to be difficult? If time is not available, what happens? What I will now take you through are certain algorithms, which are essentially modifications of the difficult airway algorithms, unique now to these settings of facial-maxillary trauma. If you're in a time constraint, call for help is obviously the first, and you try to figure out where is the trachea. If it is lacerated, exposed, secure it to the chest and intubate the trachea directly. That's possibly frightening, but easier done. Then find out if there is an airway which is obstructed above the larynx. If it is obstructed above the larynx, prudent would be to establish a surgical airway. If you have time, tracheostomy under local infiltration, pressed for time, surgical cricothyrotomy. If it is not the case, but there is a failure to maintain oxygen saturation above 90%, again, the go-to would be to establish a surgical airway as quickly as you can. Surgical cricothyrotomy in this case possibly takes precedence. And if you have a little bit of time, then tracheostomy. To buy time, you can then possibly think of attempting a rescue device like a supraglottic airway, as long as you are not interfering in the time that you have to prepare for the front of neck access. Patient is maintaining a saturation above 90%, but you might still have to go in early. It says if you can recognize there is crepitus in the neck front of the chest, or you suspect there is an expanding hematoma over here, The other reason could be that the person is in shock. In this situation, the go-to thing would be rapid sequence induction intubation with a double setup. And if you still again anticipate that rapid sequence induction intubation might be difficult, call for help, think of the other alternative approaches. Fiber optic guided intubation, theoretically possible, but practically if you have blood in your oral cavity, pharynx, larynx, which obscures the view, makes fiber optic guided intubation very, very difficult, but still can be a possibility. The better approach would be possibly an awake look intubation. What is RSI with the double setup? Nothing but direct oral intubation things, as well as emergency cricothyrotomy sets being ready before you try to manage the airway. In this scenario, it is possible that you can get into the failed airway scenario where you're failing to intubate. You might also have a scenario where you're failing to also oxygenate. In this case, the alternative that you have is one more attempt at a rescue supraglottic airway. But remember, with a hypopharyngeal pathology, it can only get worse. So keep this in mind. If oxygenation is possible and you still have time to prepare for of the surgical airway, you can have a second look with a video laryngoscopy or a direct laryngoscopy, again with a change in position and blades. So that was about when you had no time. Now let's think about scenario where you have some time, but you think that the airway is anticipated to be difficult. What you will do will depend a lot on what kind of injuries you are looking at, the patient attributes which are making the airway anatomically difficult, skills of the person who is going to manage, and the resources that are available. Most centers, most algorithms will tell you that if you have time and you're suspecting an anticipated difficult airway in a setting of facial-maxillary trauma, the go-to thing is planned early tracheostomy, spontaneously breathing, awake under local anesthetic infiltration. In this scenario, if you are pressed with time, you can go in for a rapid sequence induction intubation with a double setup. But even in a setup of anticipated difficult airway, you start asking the same questions that you have asked as in a difficult airway setting. Is bag mask ventilation going to be easy? Supraglottic airway placement is going to be easy? Will laryngoscopy be easy? Is the patient stable physiologically? The best choice is a rapid sequence induction with a double setup. If the answer to any of these is no, then the go-to option is an awake look intubation. Why is it important to know the physiological status? Essentially, drugs can cause further cardiovascular collapse, and you have to be prepared with boluses of fluids, or prepare them with boluses of fluids and vasopressors prior to doing the RSI with a double setup. What is awake look intubation? Nothing but trying and doing on a spontaneously breathing patient with topical anesthesia, direct laryngoscopy or video laryngoscopy. Remember that the excessive blood or secretions may limit the effectiveness of topical local anesthetics. Some people might try sedation. If you ask me, I would possibly not. Now, if you are doing awake look intubation and you can see the vocal cords, what will you do? Would you intubate directly without using any medications, or you withdraw the laryngoscope and perform a standard RSI? I would go for the former and possibly intubate the trachea there and then. Let's come to another scenario. Bag mask ventilation is difficult. Supraglottic placement is also anticipated to be difficult. You do an awake look intubation, which is unsuccessful. Now, what approaches can you then take? Yes, you can try video laryngoscopy. Some people suggest even an intubating laryngeal mask airway, but the best options would be, if you have time, or awake tracheostomy. If you are pressed for time, surgical cricothyrotomy. Now let's look at the best case scenario. Time is available, airway is not anticipated to be difficult, but remain alert, as we have discussed previously, for a sudden airway compromise. Be ready with your airway card and set for rapid sequence induction with a double setup. Always anticipate cervical spine and have them on a cervical collar. If the mechanism of injury suggests a high velocity crash, impact, fall from a height, and airway management is always with cervical spine control. If the cervical collar is in situ, should it be removed during intubation? Yes, it can be, but have maintained inline stabilization, and video laryngoscopy can make your life more comfortable in this scenario. It gets to another scenario. Mills is being applied, RSI with a Celix is in progress. On laryngoscopy, you are unable to see the cords. What will you do? Preferred is relax the spinal immobilization. If there is a trade-off between hypoxia that is developing and spinal cord injury due to spinal column movement, hypoxemia gets precedence. What about chin lift, head tilt, and jaw thrust? Angular motion, displacements are all more with head tilt, chin lift than jaw thrust. So if you need to clear the airway, the go-to would be a jaw thrust maneuver. Now, for laryngoscopy and intubation, in this scenario, what is the best head position or the neutral position? Preferred, many people would say advocate that it is the neutral position is the head which is immobilized on a hard, rigid backbone. But if you go by MRI studies, you'll find that the optimal spinal canal to spinal cord ratio is best when the occiput is elevated by 2 centimeters to 4 centimeters. Between direct laryngoscopy and video laryngoscopy, is video laryngoscopy better? Yes, the number of net movements are lower and immobilization is better with video laryngoscopy. There is always an increased risk of regurgitation and aspiration in this group of patients. You have to assume them that they are in full stomach, and plus the bleeding from the upper airway, the blood is swallowed and it accumulates in the stomach. Option of decompressing, the role of nasogastric tube is a little controversial, especially with fractures over here, and Celix maneuver, how effective it is extremely, extremely debatable. Between cricothyrotomy and tracheostomy, which do you do when? I've discussed this previously. If it's emergency front of neck access, time pressed, surgical cricothyrotomy. Planned, you have time in hand, more definitive is tracheostomy. Come to surgery. The type of surgery, especially how much is occlusion going to be a factor for the surgeon, and at the end of surgery, will there be an intermaxillary or maxillomandibular fixation? So if the surgical plan is MMF or IMF, what would be your airway plan? You obviously have to leave the oral cavity for the procedure. You cannot have an oral endotracheal tube. If it's only in the intraoperative phase, if there is no contraindication, a nasal tube or a submental intubation or tracheostomy. If it has to go on in the postoperative period, the IMF or MMF, your option is tracheostomy. If not contraindicated, nasal intubation. Nasal intubation, remember, is a big no with mid-face structures and fractures at the base of the skull. So let's come to a scenario wherein a patient comes into the OR with an endotracheal tube in situ or a supraglottic airway or a cricothyrotomy or tracheostomy. If it is tracheostomy, it is good. Cricothyrotomy prior to surgery needs to be converted to a tracheostomy. With a supraglottic airway in place, a prolonged surgery, panfacial fractures, mandibular fractures, plan is mechanical ventilation in the postoperative period, should convert it into tracheostomy. If that is not the case, do not continue with the supraglottic airway, replace it with an oral endotracheal intubation or maybe, and then a submental intubation. Oral endotracheal tube in situ, again, if it's a panfacial fracture which is to be repaired, needs postoperative MMF, go for a tracheostomy. If it is only intraoperative occlusions, the plan and you're planning extubation, submental intubation or if not contraindicated, nasal intubation. So what is submental intubation? In scenarios where nasal intubation is contraindicated, you need occlusions, the surgeon needs rather occlusions, and you're trying to avoid a tracheostomy and you're planning extubation, then you can do this. And it is, remember, contraindicated in patients with comminuted mandibular fractures. What you essentially do is make a 2 centimeter incision beneath the mandible, blunt dissection to the floor of the mouth, and with a forceps, catch the oral endotracheal tube and bring it out over here. It has its complications like bleeding, damages to nerves, damages to glands, and infections. So to wind up, I would say the airway management in complex maxillofacial trauma, the key points are airway management is always with cervical spine control. Airway assessment is to determine the criticality of time and to figure out the anticipated difficulty in airway control. Always wiser to have an airway control early. The things that work best is rapid sequence induction intubation, always with a double setup. If in doubt, surgical cricothyrotomy, if you're pressed for time. If you're not pressed for time, a more definitive like tracheostomy under local anesthetic infiltration. For surgical procedures, understand what is the surgery that is going to happen and then decide on the airway plan. And this is where there's a huge role of submental intubation. Thank you once again for this opportunity.
Thank you, Dr. Gupta. Next, we have Dr. Rajesh MC. Over to Dr. Rajesh MC.
Respected seniors, my dear friends, let me thank the organizers of ISA Kerala and ISA Malanad first for giving me an opportunity to express my views and for congratulate them for the wonderful arrangements for the ISACon. So I have no conflict of interest and no financial support. And over the next 80 minutes or so, I'll be talking about the basic concepts in damage control resuscitation, about the restricted use of crystalloids, use of vasopressors, and about the trauma-induced coagulopathy and approach to blood transfusion and the use of antifibrinolytic agents. And the goal in damage control resuscitation is to arrest bleeding, clean the contamination, and restore the normal physiology as much as possible. And here you are balancing the goal of organ perfusion with the risk of rebleeding by accepting a lower than normal blood pressure. That is the basic concept. And if the patient is taken up for a damage control surgery or an interventional procedure, you have to discuss about the risk of patient having with the permissive hypotension and with the ongoing bleeding to the surgeon or the interventional physician, and to limit the procedure to less than 90 minutes as much as possible, because with more than 90 minutes, the risk will outweigh the benefits of the planned procedure. So in balanced resuscitation, you are doing hemostatic resuscitation along with the controlled resuscitation. And along with this, you have to address the coagulopathy as early as possible, and the judicious use of blood products and vasopressors, and the use of tranexamic acid. So this is a basic concept in damage control surgery or damage control resuscitation. Like you are employing the permissive hypotension, you are minimizing the use of crystalloids with the early use of blood products in a 1:1:1 ratio, or in the with the early hemorrhage control. And along with this, you have to address the problem with the hypocalcemia and hyperkalemia with the massive transfusion. So in damage control resuscitation, you are you have to limit the crystalloid intake because most of the studies have shown that aggressive volume administration can increase the secondary abdominal compartment syndrome, coagulopathy, multiple organ failures. And the use of vasopressors in addition to fluids to maintain the target pressure is now encouraged. And in the event of patient has got a cardiac dysfunction or myocardial infarction, you can use inotropic agents judiciously. And now the study, most of the studies has shown the harmful effects of colloids, and it is now that much not a popular agent in trauma resuscitation. Now it is well established that systemic inflammation follows polytrauma, which sets in as early in trauma, and that means you have widespread systemic inflammation, and the organ perfusion to vital organs may be affected. That's why you have to use vasopressors in early trauma after giving fluids or blood products, and that is required to maintain adequate systemic perfusion. And once you are using vasopressors, the physician must be extremely vigilant because it can mask worsening bleeding and hypotension. So what is the optimal blood pressure in permissive hypotension? Like the most of the studies have suggested as a range of systolic blood pressure between 80 to 110 millimeters of mercury. But there are certain exceptions, like a patient with traumatic brain injury or spinal injury, where you have to maintain somewhat higher mean arterial pressure. And now the concept is talking hypovolemia. You encourage the patient to communicate with you, and as long as the patient is talking, that means there is enough cerebral perfusion and the cerebral auto-regulation is intact. And how long we can continue permissive hypotension? There is no controlled studies to show the safe limit, but more or less it is accepted that 60 minutes of permissive hypotension followed by a gradual return to blood pressure. So this is a landmark study done by Morris and et al., published in Journal of Trauma. It's actually a randomized controlled trial, and they have compared between two groups, one with the 50 millimeters of mercury mean arterial pressure and the other with the 65 millimeters of mercury mean arterial pressure. And it has shown that patients with in the lower range, like 50 millimeters of mercury, has got a better outcome than those with the 65 millimeters of mercury. But a word of caution is that there is the evidence is lacking to support the role of deliberate hypotension among patients with the blunt trauma. And it's a risk factor of poor outcome in patients with the traumatic brain injury, I have emphasized earlier, and in elderly patients who already have an autoregulation set at a higher range. And patients most likely to benefit are those with the penetrating trauma and significant hemorrhage, who has to undergo damage control surgery or interventional procedures. What about use of intravenous fluids? How much fluids and what type of fluids we can use? Previously, the ATLS guidelines was to use 2 liters of crystalloids by rapid infusion. Now it has changed to 1 liter of fluids because they now recognize the harmful effects of over-administration of fluids. And the use of isotonic crystalloids is now encouraged, and if facility is available, you can use even balanced electrolyte solution, which has got better outcome. And what about hemostatic resuscitation? It is the use of blood products as a primary resuscitation fluids along with the balanced salt solutions in a severe injury. So the goal is to blunt the development of traumatic coagulopathy, because it sets very early in once the patient has sustained a trauma. And there's no current worldwide accepted algorithms between the ratios of different products, but some of the institutions, most of the institutions follow 1:1:1 with the red cells, FFP, and platelets, which is supplemented by cryoprecipitate, because these ratios may be modified as with regard to the local availability of products. And the decisions to transfuse must be based on estimated blood loss, clinical signs, along with the bedside testing. And I'll come to that. If in urgent there were scenarios that you can use type-specific blood, and in extreme situations, O group blood can be given. And a transfusion is rarely indicated when the hemoglobin percentage is more than 10 gram, and it's almost always indicated when the transfusion, when the HB is below 6 gram percentage. Between these two range, it is the clinical judgment and estimation of the ongoing loss. And but you have to keep in mind that hemoglobin percentage doesn't decrease for several hours after acute hemorrhage, because there is active compensatory mechanisms, and the visual estimation is always underestimated. And what about the lab investigations? We have usual lab tests like hemoglobin, prothrombin time, APTT, and fibrinogen levels. Along with, now there is increasing emphasis on applying bedside test, viscoelastic tests like thromboelastography and rotational thromboelastometry. So because it can characterize the coagulopathy and actually pinpoint the deficiency of which coagulation factor the patient may require, and you can substitute accordingly. And normalization of the ABG to less than 2 in a 24 hours means a good prognosis. So I told you that now there is emphasis on correcting the coagulopathy as early as possible, because now it is recognized that there is once the trauma happens, there is a widespread systemic inflammation and the coagulopathy, which leads to the coagulopathy. And of course, it can be worsened by the metabolic acidosis and hypothermia. And it can start within minutes of patient sustaining the trauma. So once the coagulopathy disruption is there, it is a prediction that a patient can prognostically say that the patient can go for organ impairment, infection, and death. And now after CRASH-2 trial, there is an emphasis on administration of the tranexamic acid. Now, this is the lethal triad of trauma: the coagulopathy, acidosis, and hypothermia. Once the injury happens, there is a hemorrhage and impaired tissue perfusion, which leads to metabolic acidosis, and there is exposure to the tissues, which can lead to hypothermia. These three, like the coagulopathy, acidosis, and hypothermia, can complement each other and worsen the situation. So your aim is to break the cycle between the interaction between these three agents of hypothermia, acidosis, and coagulopathy with active rewarming and early component therapy, damage control surgery or intervention to stop bleeding, and the early use of fibrinolytic agents. So the active rewarming should be started along with the efforts to correct coagulopathy. The fluid resuscitation, whatever fluids you use for resuscitation, and the blood products should be warmed, and you can use whatever warming techniques you have at your disposal, like warming blankets or overhead warmers or radiant heaters. And the operation room should be kept in a thermoneutral range. And the persistence of hypothermia means there is an ongoing hemorrhage or unresolved tissue perfusion. How to reverse metabolic acidosis? Should we use any pharmacological agents? The answer is no, because it can even increase the carbon dioxide load, and the best is achieved by maintaining the tissue perfusion with your resuscitation techniques and with the judicious use of vasopressor agents. So what about the use of pharmacological agents in trauma resuscitation? After the CRASH-2 trial, the role of fibrinolytic agents like tranexamic acid is well established. The suggested dose is 1 gram over 10 minutes, followed by another 1 gram over next 8 hours. And it has shown to reduce the probability of patient receiving blood transfusions. And now the WHO has added tranexamic acid in the list of essential drugs. And the CRASH-2 has shown that it has no impact on the traumatic brain injury outcome. So what we know about the CRASH-2, there is a 1.5 reduction in 28-day all-cause mortality in adult trauma patients with signs of bleeding, And tranexamic acid has got the greatest impact with the patients coming with severe hemorrhagic shock with like systolic blood pressure less than 70 millimeters of mercury, and there is no increase in vascular occlusive events. And what about the timing of administration? It has to be given as early as possible as per the evidence from the CRASH-2 results of the CRASH-2 trial. And it is now recognized to emphasis to give even in the remote damage control resuscitation, like you can give it in the ambulance itself. And early administration in less than 1 hour is associated with the greatest reduction in death caused by bleeding. And between 1 to 3 hours, it is still effective. And after 3 hours of injury, it can even worsen the outcome. But we don't know about the impact of tranexamic acid or any other fibrinolytic agent on damage control resuscitation and massive transfusion scenarios, because those kind of patients were not included in the CRASH-2 trial. And whether fibrinolysis testing should be performed before considering tranexamic acid, that also is not clear. And what is the optimal dose? Because CRASH-2 study has taken only one dose range, like 1 dose, like 1 gram IV over 10 minutes, followed by 1 gram in 8 hourly. And is it associated with higher seizure rates in traumatic brain injury? But that was more or less addressed by CRASH-3 trial and is found to be safe. And what about fibrinogen concentrate? The fibrinogen levels decreases more rapidly to critically low concentrations than other coagulation factors. And 6-hour mortality was significantly lower in patients receiving fibrinogen. And if you don't have a fibrinogen, you can use cryoprecipitate, which is an alternate source of fibrinogen. So coming to the massive transfusion protocol, I'm sure that most of the institutions dealing with the major trauma will have a blood transfusion committee, which includes an anesthetist also, and there should be a massive transfusion protocol in place. And the protocol, they can have their own protocol with availability, with the planning has to be done with the available resources. And the thing is that you have to identify the patients as early as possible who request massive transfusion protocol. And once it's activated, massive transfusion protocol is activated, the blood bank will issue O negative RBC, type AB FFP, and platelets derived in 1:1:1 ratio. There is different scoring systems to identify the needy patients, like TASH scoring or ABC scoring, like a trauma-associated severe hemorrhage scoring system or assessment of blood consumption scoring system. And type-specific blood can be issued once the cross-matching is done. And it's always bundled with the administration of calcium and fibrinogen. What about the use of recombinant activator 7? And in fact, there is no major studies have shown the effectiveness of this agent. Even the company's supported study itself has shown that it has got not much effect on traumatic hemorrhage. But by the latest European guidelines on management of bleeding and coagulopathy in following trauma, advise that you can still use off-label once you have considered all other accepted techniques to arrest major bleeding. So to summarize, damage control surgery has to be planned, and it has to be employed as early as possible, with the limiting to 90 minutes, less than 90 minutes, because the risk can outweigh the benefits. And the permissive hypotension in selective patients with and the use of active rewarming techniques as once the patient presents into the casualty, and limiting the use of crystalloids with the judicious use of vasopressors, and aggressive hemostatic resuscitation with the point of care viscoelastic test if possible, and the early use of tranexamic acid, and the correction of the electrolyte abnormalities. Thank you.
Thank you, Dr. Rajesh. Now we have discussion of 5 minutes. over to chairpersons.
Dr. Zulfi,
Yeah.
it was an excellent presentation.
Thank you.
I understand that there are a lot of postgraduates in the audience. So for their benefits, I have a few specific questions that I would want you to answer. Am I audible?
Yeah, the voice is breaking, but I can make it out. Yeah.
I have put them as a, okay. What should be the PaCO to target during TBI surgery?
PSU target during TBI surgery, preferably it's better to keep between 30 and 35 millimeters of mercury.
Okay. And should the patient be actively warmed like in other surgeries, or you allow them for spontaneous hypothermia?
Pardon?
Should the patients undergoing surgery for traumatic brain injury be actively warmed during surgery as is done for other surgeries?
Should you mean to ask that should we warm up the patients undergoing traumatic brain injury as in other surgeries?
Yeah, that's right.
Basically, we do not have a clear-cut answer for that. Hypothermia, prophylactically, it has been not found to have any beneficial effects in patients where we can control the ICP by other measures. There was a lot of work that was predominantly done by Shiozaki in this area, and what was seen by them was that if we have patients whose ICP is greater, if we see a subset of patients, if the ICP is raised, hypothermia may be helpful if it's greater than 22, 23. But if the ICP is not that raised, ICP hypothermia may not be helpful. And again, there was some work done by a group of authors where it was seen that hypothermia is mainly helpful in a subset of patients where the midline shift is less than 12 to 13 millimeters of mercury and where we have a focal lesion rather than a diffuse lesion or where there is a midline shift. Then if we see the neurological outcome, there was a multicentric trial, the polar RCT trial, that has not shown that if we give hypothermia to such patients, it will transform into a better neurological outcome. So with this, the Brain Trauma Foundation guidelines also say that prophylactic hypothermia should not be practiced. Dr. Ganesh, you're muted.
Hello, am I audible? Hello. Hello, I am. Am I audible?
Yeah, ma'am, you're audible. Dr. Manisha, you're audible.
Yeah. I must congratulate all the three speakers for excellent talk and giving important calls regarding all the three topics. My question to you, Dr. Zulfikar Ali sir, practical question. Do you use hypertonic saline intraoperatively in management of severe brain injury patient intraoperatively? And second question, for ICU management, do you use anticonvulsant? Do you continue or do you first follow the strict guidelines for anticonvulsants and omit anticonvulsants after 7 days, or do you continue them for a longer period?
Ma'am, hypertonic saline we use intraoperatively. It basically, we do not have any definite protocols that we have to use hypertonic saline or mannitol. But most of us, as a matter of routine, we use mannitol. But once we have a patient who is hemodynamically unstable, there we use hypertonic saline. When it comes to the use of anticonvulsants for moderate to severe head injury right now we do use for a period of 5 to 7 days. or if the patient, he is stuck, if the mild to moderate head injury, they are not mild head injury, they are not admitted in the ICU. Moderate to severe head injury, they are admitted in the intensive care unit. There we use for 7 to 10 days. Then if the patient is improving, we taper off the anticonvulsants. Unless there is some problem, he has an evolving contusion, a new contusion is growing up, or he's having seizures, or he's not waking up, we suspect that he's having non-convulsive status epilepticus, or we go for an EEG at that time. And if we get any evidence at that point of time, we continue with the anti-epileptics. Otherwise, we try to taper it off and stop it within 7 to 10.
Thank you, sir. Question to Dr. Sen Gupta. Sir, again a practical question. For how many hours you keep the tube, submental tube, I mean to ask, overnight, 12 hours, 24 hours? What is your protocol? Or once the patient is settled, you remove the submental tube?
In our institution, it is very simple. We would not keep the submental tube in the post-operative period.
Okay.
We would see if it is. I think I mentioned in the protocol as well that if you're planning mechanical ventilation into the post-operative period, then you convert it into a tracheostomy. And so even if you had thought that you could extubate, but you think that at the end of surgery you cannot extubate, we are not comfortable in sending the patient with a submental tube into the intensive care. So we would convert it into tracheostomy and send.
Thank you so much.
Thank you.
Doctor, is there time for question? 1 or 2 questions?
No, sir. With the
Okay.
time, we have to wind up.
Okay. Thank you very much.
Thank you all.
Thank you very much. Pleasure.
Thank you.